So welcome back to the Dr. Doug Show. Today I have an interview that I think is going to really appeal to you if you are interested in learning more about your hormone levels. What I mean by that is that I talk a lot about testing hormones because I think it's a valuable tool to use in the optimization of hormone replacement therapy, whether it be postmenopause, perimenopause, or even supporting hormones in premenopause. But one of the challenges we have is around testing because blood testing only tells us so much. Some current urine tests that we use, like Dutch, we can't use from an objective perspective for dosing. It mostly helps us with breakdown, detox of estrogen. Well, today I'm interviewing Dr. Amy Divaraniya. She is the CEO and founder of a company called Oova, Oova. And I was introduced to her a couple of weeks ago in a synergy meeting around the use of hormone testing for what we're building out at LifeMD. What really struck me about what she's building is that she has developed a tool that could absolutely change the landscape of how we optimize and look at hormones throughout a woman's lifespan. So stick around while we go over what this test is, where it could be used, how impactful it could be, and then where to actually access this test if this is something you think would be helpful for you. All right. Well, Dr. Amy Divaraniya, thank you so much for joining me on the podcast and the show. I'm super excited to talk about you and the test that you've developed. There's so many things here to discuss.
Thanks so much for having me. I'm excited to be here.
Yeah. So I know I did a short intro before we started here, but why don't you just give our audience a little bit of background on sort of your history and who you are and what you've developed?
Sure. So I'm a scientist through and through. I have a PhD in biomedical sciences, focusing on genetics. But prior to doing my PhD, I was actually a data scientist in pharma. And so I love large sets of data, trying to find these like nuggets of gold in these massive spaghetti balls of spaghetti that we're dealing with. But the reason that UVA kind of came about was um, being super type A. Like I set a goal and I achieve it. So my husband, or I was at the end of my PhD, and my husband and I decided now is the best time for us to try to conceive. And I just set my dissertation date. It was in 9 months. So I was like, great, let's get pregnant. Dissertation, water breaks, we get a PhD and baby in the same day. Done. It didn't happen that way. I unfortunately have always struggled with irregular cycles. And we had agreed early in the journey that we did not want to pursue an invasive path, mostly because I had a pretty deep mistrust for the medical community when it came to my fertility. I had been misdiagnosed with PCOS multiple times when I was younger, put on medications I didn't need to be on. And I just didn't want someone else to tell me how or when I could get pregnant. If my body didn't do it, it just wasn't meant to be. Very easy decision to make, super tough pill to swallow. Nothing could have prepared us for the journey that we actually embarked on. It was one of the loneliest and darkest periods of my life. I was doing everything right. I peed on everything I could get my hands on. I took my temperature every day. I used every fertility tracking app. And luckily, after 18 months, I did conceive my son, who is turning 7. But I realized very quickly that all the solutions I was using were really designed for the woman who had a 28-day cycle. And so even at the onset of my journey, I kind of set myself up for failure, right? I really had two options, chance or invasive treatments, and I'd cut out 50% of the solutions. So when you look at chance and you're sitting here and inundating yourself with data by doing all the right things, but you still can't see a pattern, it's really frustrating. And you don't really know where to turn for solutions. And so what I started doing was like, okay, what I'm missing is really understanding what my hormones are doing because that dictates everything in our cycle. It dictates our cervical mucus. It dictates that BBT or the basal body temperature that I was monitoring every single day. Every single symptom that I was tracking was basically dictated by how my hormones were behaving. And so I realized if I understood my hormone pattern, I'd be able to take my journey into my own hands and actually make the right choices. So that's really what the foundation for UVA came about. I really wanted to provide women with data so they can make the right choices for their health, whether it's trying to conceive or navigating any other phase of life. I realized that that pain point I was solving for was not limited to fertility. It really scaled throughout the entire spectrum of women's health.
Yeah. Amazing. Well, thank you for sharing that. It's always hard to talk about dark times, but dark times often lead to bright futures, right? So you've got this cool thing, you have this cool test, and I was introduced to you through our CEO of LifeMD, and we were talking about potential collaborations and like what this test could do in different audiences and different clinical use cases. So why don't you talk a little bit about the test? Like, what is it? What was it designed for, and then what's it currently doing?
Sure. I'd like to consider Oova to be more of a hormone health platform because it's not, like, yes, we use a test to get the data, but the insights are really meant to be on the platform because we're not siloed into specific use cases. I can quickly show it to you and I'll describe it for
Yeah,
your audio
absolutely.
listeners too. But our kits come with 30 of these test strips, look very much like a pregnancy test. These are disposable. 15 tests measure luteinizing hormone and progesterone, and 15 measure estrogen, and it's all done through urine. So what a woman would do is, depending on what her health goal is, the app would kind of navigate her to what hormone to test on which day. She would then collect a urine sample on that day, dip the appropriate test in there, wait 10 minutes, and then scan it with her phone. There's no device, there's no attachment. You're literally using these amazing cameras that we're always carrying in our hands,
Right.
and we've turned it into a diagnostic. So once you scan this, thanks to COVID, everyone knows what these QR codes are. I promise you, we had the QR code in our design before COVID. It just really reduced our learning curve. But you basically get your quantitative hormone levels within seconds once you scan this test. And
Yeah.
when I say quantitative, it's quite accurate. We go out to two decimal places, but the most important thing is we also contextualize it for you based on what your health goal is. Because our goal is not to just inundate you with data. It's to also educate you and empower you to really take control of your health journey, whatever that may be. Um, and then the beauty of the entire platform is that it is HIPAA compliant. So if
Mhm.
you're working with a clinical team, you can also seamlessly share your data with your doctor if you want.
Yeah. So when this was introduced to me, I mean, you were introducing it to me through our call that we had in that meeting. I mean, my like I don't know if my mouth was open as I was listening to you describe this, but as a clinician who's been very deep in the hormone space and working with women and through all phases of life, one of the biggest challenges we have is what is going on with your hormone. I mean, we're guessing, right? For postmenopause, I guess that gets easier. But even then, once we start replacing, we're still guessing all the time what's
Mhm.
happening with your hormone levels. And the standard of care is well, I guess there's two. One standard is don't ever test because it's all over the place. That's not my preferred standard. The standard of care I like is through serum. So we use blood, but we know that blood only gives us the limited data, which is what's happening at the time of the blood test, right? And this is such a challenge because especially for our women in perimenopause and our cycling women, we have to send them over and over again to the lab, keep getting, like, let's do it on days 12 and 21. Let's do it on days 3 and 20, like it just gets so overwhelming. It's very challenging to get all the data, and it's going to potentially vary from month to month. So can
Exactly.
you give me a sense of from a user perspective, how long are women and how frequently are women using this test? Because it's not quite daily, or is it daily? Or maybe just walk us through all of that.
Sure. So it depends on your health goal, right? And so we can customize your journey based on that quite a bit. Ideally, you would use Uva daily for 1 to 2 months. And again, this depends on your health goal. If you're trying to conceive, it's very different than someone who's navigating perimenopause versus somebody who's trying to manage their symptoms, right?
Yeah.
So this kind of broad strokes how we would intend you to use it. We would love for you to use it daily for 1 to 2 cycles, because as you said, there's variation that happens cycle to cycle.
Yeah.
And what's also interesting is, and we're starting to really see, not starting, but we see this pretty heavily in our data. Well, women typically they alternate which ovary they ovulate from. Their cycle varies like that.
Interesting.
So I was actually doing a consult with a woman one time, and she, like, you get the whole story when you get on these consults, right?
Right.
And what she said is, as she's telling me about her question, she says, "Well, when I ovulate from my left side, I have a 27-day cycle, and when I ovulate from my right side, it's a 32-day cycle." And then moved on to, like, getting to her question. I was like, "Wait, wait, wait. How do you
What?
know that? How do you how do you know that?" And she's like, "Oh, Uva told me." And what she was doing is she was actually logging her pain,
Yeah.
and she noticed that her it was alternating left to right right around ovulation, and her cycle length would also correspond to that. And then her progesterone levels, what we noticed, because, like, now you've highlighted this new finding to me, let's look at your hormone data accordingly. We also noticed that her progesterone was not as strong every other cycle. So you start to really uncover a lot of value when you see the hormone trends over multiple months, because they
Yeah.
do vary cycle to cycle.
Yeah.
And the unfortunate part is that, and I don't fault like the clinical team at all. This is how clinicians are trained to get blood draws, and you just cannot get daily blood draws.
No.
It's not feasible unless if you're going through IVF,
Yeah.
right? Any other woman is not going to do it. We're providing that same level of granularity and accuracy, but in a much more seamless way, non-invasive way, and it's accurate.
Yeah. Well, let's talk about the quantitative nature, because right
Hmm.
now I have a lot of providers that watch our show too, because they're trying to figure out how to manage the patients that we're all
Sure.
trying to co-manage. And when I think quantitative, I'm thinking, yes, we need numbers. I immediately, when I think urine, I think of dried urine, I think of Dutch
Yeah.
precision analytics, right? So can you walk us through the difference between a Dutch test versus Oova, and like how they're different?
I mean, it also depends on which Dutch tests you get, but ultimately you're dealing with a dried urine sample.
Right.
And you're going to have to extract that dried urine, dilute it, make it liquid again, and then run it through to get the actual urine concentration or the metabolite concentration. We bypass all that. You're talking about wet urine in real time,
Yeah.
and you're getting the results within seconds. The other thing with Dutch that I think is kind of problematic is that you don't get the results right away. You have to mail those samples in. You have to then wait for the analysis and then get the results and the report back. So everything is retroactive. What we're initiating here is you can actually do real-time care.
Yeah.
That's a game changer for the space.
Yeah, absolutely. And I do, we use the Dutch test. I like the Dutch test,
Mhm.
but looking more for estrogen metabolism
Sure.
and the other things that it can measure too.
Absolutely.
Because we're not doing that with Uva, but the power of Uva and what I want to get into in these different episodes of life for women is we're talking about like quantitative hormone levels that we can compare to serum levels.
Correct.
Right.
Yes, and let's be clear. There's a place for Dutch and there's a place for Uva. You cannot say that 100% of your patients are going to get what they need from Uva because we're only measuring three hormones. Dutch is measuring other hormones. So let's be
Right.
very clear there. It's
Right.
not a one or the other. It's which one is best for my patient. Here's another option.
Sure. Yeah, and we still have, we have the use cases for Dutch. And again, I
Mhm.
do like that test. We do still use it. But one of the areas, and I have to correct a lot of our providers when we train them on this, is that we cannot adjust dose of our
Correct.
hormones based off of levels on Dutch.
Yes.
What's not what we use it for. It's not what it's designed for. So, okay, let's talk about some different times of life throughout the
Sure.
lifespan for women. So let's just start with who is mostly listening to this from our channel's perspective, which is women post menopause.
Sure.
So if our women are post menopause, they're on either on HRT or not. And if they're not, this test isn't going to really provide a lot of value because we know we don't have significant estrogen, we don't have LH, we don't have progesterone. Am I correct in saying that? Like there's really not value unless we're trying to do something with our hormones.
I think it depends.
Okay.
Um, it's medicine, it's science, it's imperfect, right? So yes, you might be postmenopausal, but are you experiencing symptoms? Because if you are, there could be a hormonal culprit for that. And then you might find some value here. I will say that we are not heavily designed for postmenopause at the moment because
Yeah.
you're right, majority of women don't have that many fluctuations. But what we are seeing are women who have had a hysterectomy or have been surgically put into
Mm.
menopause that are still experiencing these symptoms, and they
Oh,
are seeing a
interesting.
hormonal change happening that they're able to attribute to the symptoms. So I think it depends on a use case.
Yeah, that's an interesting use case. Yeah, I could see especially a partial hysterectomy, right? So we have some women who
Mhm.
have undergone the removal of the uterus. They still have ovaries. They think they're still cycling. Sometimes they can't tell. And so we've had
Exactly.
women who we say like, well, when did you go through menopause? They're like, I don't know. And
Yeah,
so, yeah, so that actually, yeah, that could be very useful. Like, are you still cycling?
exactly.
Are you still having these fluctuations? That would be really important to know, especially like, when do we start HRT? How do we know what's happening? Maybe you're catching it in blood or not, maybe not. Yeah. So
Exactly.
I like that.
And so there's this concept that I constantly say, like when we go in for blood work, we're not letting our cycle dictate. When we go in for blood work, we're letting our calendar dictate
Yeah,
that. So they don't always align,
of
right?
course.
And it's really hard to draw a line from one data point, which is what you're asking clinicians to do when you're doing a serum draw. And that's why I think the technology needs to move faster. And I think we're really at the forefront of that. But the adoption needs to also happen. And I think we're starting to see a lot of value there. The other thing I'd love to clarify is I think right now, and I think we know, like right now, menopause is defined by going 365 days without a bleed. I want to change that
Yes.
because it's not always associated with the bleed. It's have I ovulated the last 365 days, right?
Yeah. That's that's a really important point. You were going to say more. I want you to say more about that, but I have some thoughts around that because I've thought this exact same thing.
I think there's the reason that we rely on the bleed is because you're reliant on the data that you can easily see. You could not capture trend hormone data over time before Uva. You were limited to a blood draw. And now you're
Yeah.
basing that on a single annual blood draw. It's hard to make a line again. But all you have is a bleed. What I'm saying now is we're actually able to uncover what's happening internally and figure out, is this woman ovulating or not? Is it a healthy ovulation or not? Is the corpus luteum forming properly?
Yes.
Or is the quality just dropping as time is going on?
Yeah.
That is great information for her as a
Well,
patient and a
yeah.
clinician to have.
I just had this conversation with a patient today. She's perimenopausal. She's already on testosterone from another provider because she's having symptoms. And so we start talking about, are you measuring your basal body temperature? Do you know if you're ovulating? She's like, I don't know, but my sleep's not good. Like I'm having, she describes these symptoms of like, estrogen dominance, not having progesterone. I'm like, we need to know because
Right.
she's young. I mean, she's in her early 40s, and
Okay.
I'm concerned that she's not ovulating. So I don't know. I don't know what we call it. The point at which a woman stops ovulating but continues to have a monthly or irregular monthly bleed. But there's definitely a space there. This is a specific like window of opportunity to optimize hormones that we're not capturing at all.
Absolutely. And what you just said about am I estrogen dominant or not? How are you going to make that call with a single draw?
Right.
We're very easily able to see that. And I'm sure the other interesting point is you might see elevated estrogen and reduced progesterone on the day that the blood draw happens, but it could also be dependent on where she's in her cycle.
Right.
You will know if she has irregular cycles or irregular bleeds, right?
Right. Yeah, it becomes so challenging because we'll say, oh, well, if you have a 28-day cycle, right, going back to what you started with, if you have a 28-day cycle around days 12 and 21, we should be able to get a sense of what's happening. But like you said, we're trying to draw these curves between very few data points.
Yeah.
And just having treated, I don't know how many women in this situation at this point, like it's not easy.
It's not. And I think that's one of the leading reasons that women feel dismissed because they're being forced into this mold and they may not be fitting that. But
Right.
we just don't have the models yet. And when I say me, I mean the clinicians, like don't have the models
Sure.
yet to be
Yeah.
able to account for those outliers that are
Yeah.
truly not outliers anymore. We are the majority of the
Well, yeah,
population.
I was going to say, no, I think the mold is that there is no mold,
Hmm.
especially in this, like the midlife, mid to late 30s up through the current definition of menopause. Yeah, absolutely.
It's just that science hasn't caught up, right? Like the research hasn't caught up. We still consider like peak fertile window to be early 20s. Maybe that's the case, but that's not when women are trying to get pregnant anymore.
Right.
Like, God forbid if I had had a child right out of college, like that would not have been
Right.
great. So like just the average age of women having children is growing up, but science hasn't kept up and the research hasn't kept up. So we don't know how to treat today's women.
Yeah, no, I totally agree. So then let's like kind of double click on the ovulation piece. Like, why don't you give us your sense of what you see? I have my own thoughts on what happens, but you mentioned the corpus luteum, you mentioned like progesterone. Can you just kind of walk us through this and break it down for people that aren't familiar with the cycle? Like, if you're not ovulating, what's happening? Why is this important?
So, I'll go one step further or back, if that's okay.
Yeah, yeah.
Let's just talk through these three hormones and what's happening in the
Sure.
cycle and why they
Let's do it.
matter. Because I feel like a lot of people actually don't know this. Okay, so it's called a menstrual cycle because these hormones are working in a cyclical pattern and they have certain behaviors and they're responsible for certain steps in that cycle. You have to remember that we as humans are evolutionary creatures. As a woman, your job for the population is to repopulate the earth. So the menstrual cycle is designed to help optimize your chances of continuing this population, right? So when you're having your period, the period is the first part of your menstrual cycle. That is not the length of your menstrual cycle. It is a bleed. It is when all your hormones are at their baseline and the body is being told, hey, we did not conceive this month. Let's kind of purge everything and let's start over, right? Once the period ends, your estrogen starts to go up. Now, the estrogen has a role in the first half of your cycle to ping the pituitary gland to release LH. LH is, or luteinizing hormone. It's not released as a steady stream. It's released in little bursts. So imagine now this gland is getting pinged more and more as your estrogen levels are rising. That LH level is going to continue to go up. That LH now goes and talks to your ovaries saying like, hey guys, let's get ready to release an egg. And a follicle forms and it starts to, once the LH gets so high, the ovaries like, great, time to release an egg. The egg starts to move down the fallopian tube and it starts to form a corpus luteum, which is this like yellowish structure around the egg. That corpus luteum starts to release progesterone. Progesterone has a very specific role here because what it does is it makes the uterine lining as thick and cushiony as possible so that if that egg gets fertilized and you get an embryo, it can nestle and implant into the uterine lining. If that progesterone is not emitted properly, that uterine lining won't be the most conducive environment for an embryo to implant. And even if you form an embryo, you won't end up with a pregnancy or a viable pregnancy. It just won't be able to attach, right? So that progesterone is so critical there. At this point, you will see the progesterone elevated. You'll also see the estrogen start to come back up. If conception happens, that embryo starts to overtake the corpus luteum's role of progesterone and it starts to release even more progesterone and beta HCG. So you'll see both those hormones start to go up and you clearly have a pregnancy. If no pregnancy happens, that progesterone and that estrogen plummet and it tells the body, hey, time to reset. We didn't get pregnant this cycle. So what the bottom line is that these three hormones work in such a cohesive manner. If there's an imbalance with one of them, you can imagine how that has a massive downstream effect on the entire cycle. And all of those hormones work together to end up in symptoms and give you all the things that are associated with your menstrual cycle.
Right. Yeah. And I think that's really misunderstood because when women are talking about symptoms around their cycle, oftentimes it is related to the progesterone piece. Not always, but oftentimes it's related to the progesterone piece. And I think it is more likely coming for a lot of my audience anyway. It's often coming from failure to ovulate that we don't have a good way to identify.
Sure. It
Yeah.
makes a lot of sense. I mean, what we see oftentimes, and you can just think about logically, we think about PMS, right? Think of a broader population. Why do a lot of women experience PMS? When you look at their hormone levels, it's because their progesterone plummets.
Yeah.
Typically, your progesterone should taper off. It's kind of like think about going to an all-inclusive resort where like you've been drinking all day and then you come back home and you're like in withdrawal, right? Like you just want to drink, or even like a little buzz that's gone now. That's kind of what progesterone's doing for you. It's giving you this buzz, and if it plummets, that's when a lot of women start to experience these like heavy migraines, anxiety, lack of sleep. Like there's just so many things associated with it. But there's ways to treat that. You just need to know that that's the cause of it.
Yeah, and you would be able to tell the speed at which the drop is occurring because we have so many data points.
Correct.
Yeah,
And so what we see is a lot of clinicians actually care more about monitoring their patients during their luteal phase, the second half of the cycle,
sure.
and less so about the follicular. Because if they're not trying to get pregnant, you don't really care about how that estrogen is behaving in the beginning or how that LH surge is happening. But they do care about what that hormonal imbalance is between the progesterone and estrogen
Yeah.
in that luteal phase. And we can really dig into that.
Yeah, no, I totally agree. That's where the bulk of the work is. Because I've never had an infertility case in my practice. We're never trying to help women get pregnant. So all right, let's go back to these use cases. So back to our postmenopausal audience.
Mhm.
So if they're using HRT in the form of whatever, we can actually use Oova to help to determine whether or not they have an appropriate dose based on their goals. Is that accurate?
As long as they're under clinician observation and care, yes. Absolutely. The one thing I'll say is that Uva cannot decipher between endogenous estrogen and what is coming through the
Oh,
treatment.
interesting. So for women that may or may not still be producing estrogen, that could get confusing.
Correct.
Yeah.
Well, I mean, you're just going to get a higher reading. You won't be able to tease out is it
Right.
endogenous or not.
Right.
The one thing that I think is really helpful, though, is if the woman is not metabolizing her estrogen treatment properly, you'd be able to pinpoint that very quickly and not have to wait months to be like, I'm not feeling better and the medication's not working.
And by that you're meaning that she would have high levels of estrogen because she's not detoxing it.
She would have lower levels because she's not metabolizing it.
Not metabolizing, meaning not getting it on board, not
Correct.
coming
Yeah,
in
yeah.
in whatever way. Yeah. Okay,
Yeah.
gotcha. Yeah, absolutely. Well, and I think too, this is some of the challenge we have clinically is because I am a big believer in testing, but you're still, of course, if you're doing serum, you're still just getting that one thing, and we tend to use creams or patches, and like topical delivery is inconsistent at best.
Yes.
And so
Yeah.
then it's like, well, what happened that day? And like, did you put, I love these like really high levels. I'm like, well, where did you put your cream? I'm like, oh, I put it on my forearm. And then I had a blood draw on that same arm. I'm like, well, yeah, like your estradiol is 400. So anyway, yeah, I think it would be so valuable to be able to get data over time to help us to understand what's happening from a dosing perspective. So, all right, so
100%.
that's yeah, so that's postmenopause. So now in the perimenopause space, this is where I get really excited because managing hormone levels for perimenopausal women can be very, very challenging, and that's why a lot of doctors just like they just don't even deal with it.
All
They're
of it.
like, your labs are normal, but the reference range is like 0 to 1,000. So yeah, so normal labs means nothing. We have to get more data. So then we already talked about ovulation, so we can get a sense of what's happening from an ovulation perspective. Are you getting that progesterone rise and fall? I think that's such a valuable piece of information, depending on what's happening from a symptoms perspective. What else is valuable for the perimenopause population in this test?
So if you think about perimenopause, right, like it can last anywhere from a couple of years to 10 years. You're talking about a decade of a woman's life that she
Yeah,
would be uncomfortable and not have answers and not really be able to seek proper treatment because no one knows how to treat it. So one thing that we've started doing, because I think the other issue with perimenopause is that it's so under-researched. Like no one knows how to treat it. The data doesn't exist. So we kind of took it upon ourselves, like let's put the data out there. Let's try to shed some light on what's going on in perimenopause because it is a black box. And so for the past 2 years, we have been presenting at every women's health conference with something about perimenopause. So um, just a few weeks ago, I was at ACOG, which is the American College of OBGYNs, and we presented some research showing that there's a really strong correlation between estrogen patterns and anxiety and sleep. And it's basically you see this massive decline in estrogen that happens, very similar to what I was talking about with progesterone, but it happens very quickly. And what we've noticed is that women that are on a topical estrogen, if they see their estrogen kind of starting to fluctuate a bit before bed, they'll just take another pump of their cream and they actually see improved sleep.
yeah,
So it is pretty quick. But I think that's a question that we get a lot. Like, so how quickly do you see the result of the topical in your results? Everyone's different, but we're seeing that women are actually seeing benefit by being able to track symptoms alongside the hormone patterns.
yeah,
We're seeing very clear patterns there. So I think that's one big use case, right? The other would be like obviously monitoring any medications that you're on under the purview of a clinician. Um, and then more importantly, and this is kind of some exciting stuff that's coming from our end, we're actually working on ways to help navigate women and clinicians through this like murky decade that women go through. And it's being done through clinical protocols, data, and very actionable insights. That's all I'll say about that right now, but there's a lot coming from us.
yeah.
And I think if you just pay attention for the next few months, you're going to see some really exciting things. We have some very exciting research that we'll be presenting at the Menopause Society conference this year.
Awesome. Yeah. So I think that, I mean, we could keep coming up with different scenarios, clinical use cases
Mhm.
in perimenopause because it is such a challenging time to try to understand what's happening. And that, I love that we're seeing the menopause discussion. We're seeing perimenopause come up. We're seeing all these discussions on social media and media channels, which is great, except that providers are way behind that curve as
Yeah.
far as what to actually do because we're just and I've looked at the research on this and I feel the same way. Like there isn't, right? Like we don't, there's nothing to tell us what to do as clinicians. And like even the guidelines are like, yeah, for after menopause, this is the recommendation. And for cycling women, this is, but like, what about the 10? I mean, I would argue it's potentially 15 years in between, from
Yep.
mid 30s to 50. Like, there's not a lot of evidence to help guide clinicians. And so many doctors, especially around hormones, are so afraid of litigation. They just don't want to do anything. And that's really unfortunate because so many women right now are struggling with, are my symptoms coming from my hormones? They might not be. There are other things, but they absolutely could be too. And that's what we need to be able to help women differentiate.
Absolutely. And I think it's not really anyone's fault here, right? If you look at how OBGYNs are trained, it's like only, but I think it's 28% receive some sort of peri and menopause treatment care um, lessons or lectures during
Yeah.
their residency.
Yeah.
And of that, 70% got five. That
Yeah.
was the max. That's
Yeah,
insane. When everything is focused on pregnancy and not every woman is going to try to get pregnant, but
sure.
every woman is going to go through perimenopause.
Yeah, I
Right.
say this a lot because I never disparage doctors in the traditional medical system because I've been
Mhm.
there and I know what it's like. But when I look at OBGYNs, because ortho and OBGYN sort of like, for whatever reason, we usually have neighboring ORs and like we're usually
Oh,
in the
okay.
same place. I don't know why. But it's just a really interesting dynamic when you look at OBGYN as a subspecialty. What blows my mind about this subspecialty is A, that GYN and OB are actually considered in the same subspecialty. Like, yeah, of
Yes.
course they overlap, like anatomically, but they're totally different things. And to think that one person can go through and learn everything about OB and learn everything about GYN and then also be expected to be a hormone expert, I think is wildly unrealistic. So
Absolutely.
I never disparage OBGYNs for not wanting to manage hormones because
Yeah,
they're not
absolutely.
trained very extensively in it. They really have to take that extra step, do additional training, and then build a practice around it. And there's just too much to do and like,
Yeah.
outside of that in OBGYN. So yeah, I'm excited that you're partnering with these clinicians, and I think we have a lot of potential work to do from the LifeMD perspective as well. I think there's so much work that could be done. But before we wrap up, let's just go like earlier in life. So obviously for younger women, what we would consider premenopausal women, for infertility is a thing, and we know that we can help in that space. But where else could this be utilized for that younger audience?
Yeah. To me, it's more about hormonal imbalances and reproductive disorders. Because what's interesting, and again, like I think women's health is such a journey. It's not, yes, we have phases, but there's a lot of overlap too. So I'll give you one example. We know that polycystic ovarian syndrome, or PCOS, is one of the most highly misdiagnosed um, disorders in women right now. What's very interesting is that when you look at a perimenopausal woman, many of them are saying like, hey, I think I'm in perimenopause. They're in their late 30s, early 40s, whatever it may be. But when the clinician actually looks at their data, and when we look at their data, they are not perimenopausal. They actually have PCOS and they were never diagnosed with. And we can tell that with just 2 cycles of data, right? So they've lived their entire life struggling with certain symptoms, kind of overriding it. Maybe life took over. I mean, so many things. But had they gotten this answer, we could have solved this in 2 months, or at least gone to the root of it in 2 months.
Yeah.
So to me, the more exciting part is getting women the care they truly need at the time that they need it. Maybe they don't even know they need it, but they can get that personalized care.
Yeah. Amazing. Yeah, I think about it too. When I think about where we need to get the message around bone health, I would love to get this in front of a younger and younger audience. And understanding what's happening with hormones is a big piece of this because we know based off the literature, if a woman doesn't have 5 quote unquote normal cycles, what that means, but if they don't have 5 normal cycles, including an ovulation and a normal luteal phase of progesterone, they're losing bone. And
Yep.
there's no way that most women know that. It's really rare for a young woman to be like, oh, well, yeah, I'm not ovulating. I didn't ovulate for 5 cycles this year. So like understanding that data, I think could be very, very valuable from, my perspective as the bone health guy. And then of course it has a lot of other potential benefits there too. But yeah, awesome. I think we should probably wrap it up here because this has been a lot of great information. Why don't you give the audience an idea of, if they're interested in doing this, how can they get their hands on this test or this platform? You say it that way.
Sure. If you're interested in partnering with us, I mean, as a clinician, you can reach out to our team. You can email us at info@uva.life, and our team will get back to you to kind of get you trained and get you the information to see if this is a good fit for your practice.
Mm-hmm.
If you're a patient, you can go to our website, uva.life, oova.life, and place an order for a kit. There's no prescription required. You can use your FSA, HSA dollars if you have them. And our team is here to support you. So if you have any questions or if you're wondering if like Uva can satisfy whatever situation you're in, send us a note at support@uva.life and our team will be here to support.
Yeah, amazing. And I know you're doing a lot of work going around the country, speaking at areas like Menopause Society and ACOG and all these places. So, you know, I'll definitely have those interested continue to follow you, follow Uva, follow the journey, because I think there's a lot that's going to continue to come from this.
Thank you. I'm excited about it.
Yeah, awesome. Great. Well, thanks so much for your time today. I really appreciate it. And I know that the audience is really going to love this information.
Thank you.
All right. I hope you enjoyed that interview with Dr. Amy. I hope you could tell that I'm very excited about the potential of this type of testing at home, objective, quantifiable. We can use it to identify dose of hormone replacement. We can use it to identify levels in women that are still cycling or in perimenopause, and we're questioning whether or not they're ovulating. Do they have adequate progesterone, et cetera? I think there is massive potential for this type of testing moving forward. Really looking forward to continuing to learn from Dr. Amy and what they're learning by working with clinicians and seeing how we can help to move this forward within women's health. So that's it for today. Remember that a diagnosis of osteoporosis isn't the end, but deciding to reverse it is a beginning. Here's to aging with strength and grace.